All right. You need to talk. You need to form a trainees homelessness group or something. All right. So welcome to the second session of the day. I'd like to introduce Tim Aubry. Tim Aubry is, well, he's actually approaching national treasure status as an academic, really. If you've heard anything about Housing First, it's his fault. Tim has been done one of the most impressive ever randomized controlled trials that looked at the impact of Housing First. She knew. He's a full professor in the School of Psychology here, and what else? His areas of interest include community mental health services, surprisingly, homelessness and Housing First. He is, what was the thing? Oh yes, you are the current co-chair of the Canadian Housing First Network. So, yeah, he's an advocate for and very influential in promoting Housing First and looking at housing solutions for the people that we serve. So, Tim, take it away.
Can you hear me? Is that picking up? It's on. Is that working now? Is that good at the back? Good. Great. Well, thank you, Simon. Thanks for the kind introduction. It's great to be here and have a chance to meet you and speak with you. And first I want to congratulate the organizers for I understand this is your first meeting, and it's the work that you're doing, and I think that you represent is so important, and it's actually becoming important by the day, as you know, as we follow some of the awful stories in the media about our group of people that we want to help get back into society and get integrated back into the community. I'm actually a psychologist. I'm trained as a community clinical psychologist. And I'm actually like the person that was speaking at the end. The emeritus. I've been around quite a while. And the students say I only tell stories now. I'm more of a historian than a practitioner. But I started this work around the issue of deinstitutionalization. I went to the University of Manitoba and in the 1980s, and we were scaling back and closing down psychiatric institutions. And you know, back then in the 1980s, it was also all about housing and support. And we really thought we really were going to put a real effort into getting into place a proper community mental health system. And unfortunately, that has not happened. And we're living with that today. But I do think there's hope. I think there's hope because of the kind of commitment that folks like you bring to your work. And also because of the things we're finding out about housing and support. And that's what I'm going to talk to you today about. And let's see if this will work now. There's somebody up in the booth. I was told this was idiot-proof, but has anybody used this so far, Simon? Is it? Okay. Well, listen, I'll tell you what I'm going to do. I'm going to just briefly, you all know what Housing First is, but I'll just briefly kind of do a very quick review. I'll give you kind of an overview of where we're at in terms of the research on Housing First. I want to talk to you just a little bit about the At Home Chez Soi demonstration project, which I was involved in with a whole group of people across Canada. And then I'd like to quickly run through, kind of line up the features of Housing First and how they align with what are called ideal features of a mental health intervention. And this is the work of Gary Bond and Robert Drake and Deborah Becker, who are well known in the community mental health field. And then quickly talk about, you know, in the program it says, do we need a Housing First
Progress.
I think we do. And I want to talk about what we need to bring to Housing First to make it more effective. And then finally, just some of the policy challenges we're faced around housing and support, and just talk about that in relation to Housing First. So, headway on this. There. Okay. So the first thing, and this was part of the institutionalization, we started out with what's called the staircase model. And we wanted to help people leave the hospital and get ready for living on their own. And the idea that it would be a series of stages. Unfortunately, over a period of 30 years, that didn't work very well. And it sure wasn't helping people who were out of housing and struggling with homelessness and struggling with chronic homelessness. So in the early 1990s, a Canadian actually, who was living in New York City and was doing outreach work, the kind of work many of you do, he was getting frustrated with the outcomes. He was helping a lot of people. He was trying to support them, largely people on the street. And they did a small study and asked them, how can we help you better? Like, what would make a difference? And Samson Barris, who was a psychologist, said over and over again, people said, can't you see what we need? We need housing. Yes, the services are good. We appreciate them. We appreciate your support, but we need to get into housing. And that was the beginning of Housing First. And they took a risk and they said, let's pilot a new way of doing it that would essentially collapse the staircase model. And instead of having people go through stages, we're going to see if we can support them right into housing. And that was the beginning of Housing First. And when I'm talking today, I'm talking about the model that came out of New York City called the Pathways model. It has housing and support, and it builds on the kind of support from the mental health system that we know is helpful and makes a difference. So for people with the highest level of needs, more complex needs, we have assertive community treatment, wraparound. We have over 80 assertive community treatment teams in Ontario. It's been around since actually the late 70s. It started in Wisconsin. People with more moderate needs would get case management. So the caseloads are a little higher. The support is not as intensive. You rely more on services in the community. So if we take a look at, and I did this for this presentation, it's about 400 published articles now on Housing First. The first mention of it in the literature, so you do a kind of a search in one of the search engines, it's 2003. Now, Samson Barris's group started their work in the 90s, but they really didn't start publishing till the early 2000s. And they were smart because they brought research into the picture figuring that if the results were good, they might be able to sell this to policymakers and work on scaling it up. So you can see it's a fairly active area. It takes off in 2009. There's a lot of Canadian research there. Oops, now it's stuck again. But there's also research, obviously, from the US, where it started, from Europe. There we go. There's even the beginnings of research from down under, right? Australia and New Zealand. There's a small amount of work I'll touch on around costing, economic analysis of Housing First. Essentially, the studies, they compare Housing First to treatment as usual. What's in the community right now? That's what the studies compare it to. So the at-home Chez Soi project started in 2008, a year of planning, but it really went from 2009 to 2015 and beyond. The Toronto site, you'll see, actually followed people for 6 years. It's a big study. The Mental Health Commission of Canada was involved in it. And as Simon mentioned in the introduction, it was a randomized controlled trial. And that decision was made because we really wanted to have evidence that we could bring to the politicians and say, this thing works. And we've tested it in the most rigorous way possible. So we looked at effectiveness. We also wanted to kind of deconstruct Housing First, identify the ingredients, because if it works, you want to take it on the road. You want to take it elsewhere. And I mentioned also economic analysis. So these ideal features of a mental health intervention. So this group, Bond, Drake, and Becker, they've analyzed different types of mental health interventions. And you can see from a practical standpoint, we'll walk through each of these features in terms of Housing First. So the first feature is it well defined. Okay? Now, this is what's called in mental health circles the evidence-based world. Okay? If you do a study, it gets replicated elsewhere. People maybe test something a little different, and all of a sudden there's an accumulation. Then you have evidence that says this is probably an intervention, if it's done a certain way, can make a difference, can benefit people. But you have to be able to define it. Okay? Now, Housing First, there's been a fair bit of work on defining it. There's the issue of fidelity. There's a fidelity measure that identifies all the ingredients to the recipe of Housing First. The Europe Housing First Hub has its own take on it, but also identifies a similar group of ingredients as we have here in North America. So when we talk about ingredients, there's 5 domains about it being well defined. There's the housing, so it matches people's needs. You can see some of the criteria there. There's services that match people's needs. The housing and services, the housing and support are separate. Okay, that's an idea that has been circulating for quite a long time in the community mental health world. It was circulating before even Housing First, through the folks at Boston University, like William Anthony and Paul Carling in Vermont. Is it recovery oriented? Okay, that's big right now in mental health circles. Does it help people build a new life? Pursue the things that are important to them. So is it recovery oriented? Is there choice? And then finally, there's a structure to it. So a structure, things like if you're a support provider, how many people are you supporting? That level of intensity. Programs, one of the criterion is to have a peer support provider, or maybe even more on staff, okay? So this is an approach that's well defined. Does it reflect client goals? Number two, the second feature. Is it in line with what people want? Well, as I mentioned to you, the story Samson Barris tells is when asking people in a needs assessment, most of them said, we want housing, okay? Now, there is research where people are surveyed. This has been going on since the 1980s. And in large part, not everyone, but in the range of 85% of people, including people who are out of housing, who are homeless, they'll say they want to live in the same kind of housing as everyone else, regular housing. Some people want to live communally in groups, you know, like co-ops or supportive housing. But in large part, people want to live in regular housing. Is it consistent with societal goals? Okay, so what that means is there some kind of consensus out there that housing is fundamental to people who live in Canada? Okay. Now, it's very interesting. In 2017, the federal government came out with the National Housing Strategy. In it, they talked about a human rights approach to housing. The idea that there would be a mechanisms, including legislation, that would progress towards making housing a right, the way healthcare is a right in Canada. And legislation was passed in 2019, National Housing Strategy Act, and also fairly recently, in the last year and a bit, there's an office, federal advocate for housing. So if people feel they are facing barriers, systemic barriers, getting housing, they can put in a complaint, they can get their situation reviewed. Obviously, populations can do that, and so on. And that has started now a process. Of course, an ideal feature, an intervention has to make a difference, okay? Now, what you see here, when we did at home, 5 cities, right across Moncton, Montreal, Toronto, Winnipeg, and Vancouver. The red line in this figure is housing first. Notice how it spikes at the beginning. That's the first 6 months. People are getting housing. Now, that line is 3-month periods of being in stable housing for all of the people in housing first. The blue line is treatment as usual. Now remember, treatment as usual is people can get whatever else is available in the community. So you can see the gap. Housing first outperforms in all 5 cities, treatment as usual, okay? And you can see also after the spike, the plateau. So that means there's some permanency here as we go forward. Now, the original study was for 2 years, so that's a 2-year period, but I'll show you some data in a minute for 6 years. Now, whether people received, remember, case management for moderate needs, everybody had a mental health issue, a diagnosable mental health issue to be eligible for the study. However, people with complex needs had spent time in hospital for mental health issues. They had concurrent disorders, often combined with substance use difficulties, okay? Also with complex needs, people with diagnosed with psychotic disorders, complex affective disorders. If you look though at the 2 groups, moderate and high level of needs, so ICM is intensive case management, assertive community treatment is ACT, you still get the same results. You still get that pattern of spike and plateau. The French, after we started our study out of France, and we helped them with it, we gave them our protocols and so on, they put together a randomized control trial and followed people for 4 years. And they found very similar findings as we did. 85% of people ended their homelessness for good. Okay, ours wasn't quite as high, but it was closing in on 80%. Okay, so similar findings in a replication in a very different context. 4 cities in France, and just the orange is the being in permanent housing on the right-hand side, and treatment as usual is on the left-hand side, and all those other colors are being rough sleeper, living in temporary accommodations, emergency shelters, couch surfing, all of that. So you can see the very, very notable difference between the 2 groups. When we go beyond housing, it's kind of a mixed picture. Okay, we did find if we put everybody together, all 1,000 people or so who got housing first, they did present as doing better living in the community. So they had greater improvements in community functioning. And they also reported a better quality of life. Okay, these were not large effects, though. It's important. And there was some catching up. But remember, treatment as usual is all the other services in the community. Okay, the French did find also quality of life was much better for the housing first people. And the other part of the story, the French, which we'll talk about in a bit when we get to the economic analysis, is that they had a dramatic drop in hospitalizations, dramatic drop compared to treatment as usual. We did qualitative. I just want to just spend just a couple of minutes on these qualitative findings, because in this kind of research, everybody responds differently, and you have to hear their stories. So we interviewed 200 people, about 100 or a little or so in Housing First, another 100 or so in treatment as usual. What we asked about were, over the course of the study, this was at 18 months, how has life changed for you in different life areas? Okay. And what we found was, for a lot of people, and it's not going to be surprising, we found for people in Housing First, it was truly transformative. That's the stories we heard. In fact, about 60% had no negative things to say across all of, I think it was 13 life areas. Okay. In comparison to treatment as usual, it was more of a mixed picture. There were some people, about 30%, where it was all positive, but there was also 30% where it was all negative. So you can see the differences here between the 2 groups. Another feature, very important, is the issue: are there negative consequences to Housing First? It's like any healthcare intervention. You also want to make sure, if it's experimental, does it bring anything negative? Secondary effects, unanticipated problems. Okay. We certainly heard when people were in their own housing, there were periods of loneliness. They felt isolated. They didn't want to go back to their network on the street. A lot of them wanted to really make a break, but they didn't have a lot in their life. And this is an area we got to shore up in Housing First that we're working on. So that's one issue in terms of a negative consequence. Loss of housing was another. We talk about in the Housing First world that 15 to 20% of people You can try multiple times. It doesn't work very well for them. Things don't work out. They experience evictions. Or some people want to just leave and find a different way. As I mentioned, some people may want to live with other people and so on. It comes in different studies that have been done, about 15 to 20%. Okay. But here's the thing, it's very difficult to identify at the beginning who's going to have trouble. And we tried. And we just put out a paper about this issue. We found that younger people had more difficulty. If you had a longer history of homelessness, you were at risk, more at risk. But these weren't strong predictors. Not surprisingly, people who experienced substance use difficulties were at greater risk. Obviously, if you didn't like your housing, lower levels of perceived housing quality. But the one that really stood out was the strongest predictor was whether or not people had a family doctor. And a lot of the folks that we work with in Housing First don't have a family doctor. You know that because you're working with people. And it seemed that acted as some kind of buffer for people in terms of staying in housing. The other thing I want to mention about, and there's some discussion about this, what do we know about mortality of people in Housing First programs? And certainly we know people have shorter lives if they've experienced extended periods of homelessness. We know they have lots of chronic physical health problems and so on. The French have looked at this. We're in the process of looking at this. In the French study, they did find, but it was small numbers. Out of 350 people receiving Housing First, 23 people over the 2-year period passed away in the Housing First programs versus 11 in the treatment as usual. The numbers are small. It approaches significance, but it's not significant. The other part of that story is that the treatment as usual, you lose people. You can't find them anymore. So it was a much larger group, 33 versus only 2 in the Housing First, who possibly also passed away. They just don't know. But the question in the world we're living in right now, of course, is the issue of overdoses, opioid overdoses, and living on your own. Okay. Of the 23 in the French study who passed away, there were 8 overdoses. There weren't any in the treatment as usual. Okay. We're looking at that in the Canadian data. We're doing it through, which should be pretty accurate because we're not going to lose people, through the what's called ICES, which is the provincial databases. That's the one here in Ontario, but we're going into the provincial databases in the 5 provinces that were implicated. It's a big task. It should be easier than it is, but we should have also some information on this issue. It's a very important issue to track. I mentioned the long-term positive outcomes. Okay, in Toronto, they followed people for 6 years. Those are the graphs. Again, the red is Housing First. The actual units are 1 year at a time, so the spike isn't as pronounced at the front of the graph. The top one is people with complex needs, so they're getting ACT. The bottom one is people with moderate needs, so they're getting case management. Still a gap after 6 years. The treatment as usual hasn't caught up. The gap isn't as pronounced for people with moderate needs. Okay, so but long term, what this shows is that for the group of people who end homelessness through Housing First, it's sustained. It's a long-term proposition, and that's important. The issue of economics. So another feature is, does it what does it cost? And does it reduce use of other services so that what it costs gets offset? Okay. First of all, what does it cost? Housing First with ACT, these are 2016 dollars, by the way, when we did the analysis. It costs about $20.5 thousand per person per year. Housing First with case management is about $14,000 per person per year. Complex needs, if you look at the offset, the reduction in healthcare, social services, justice-related services and contacts, about 70% of the cost is offset. So that means you've reduced services on the other side of the ledger. For people with moderate needs, it's in the 40%, 46% is offset, okay? Now, not surprisingly, people who show up at the beginning and are super utilizers of services, they have lots of hospitalizations, that's what costs the most. The offset is more than double what the program costs. Two messages from that. One is, in my world, spending $20,000 per person per year to end homelessness for someone is not expensive. Stack it up against a lot of different types of medical care, okay? Secondly, you're gonna have savings. But because some people don't use any services and some people use all sorts of services, it's going to be all over the map. And I think the focus should be on what does it cost, and it's quite reasonable, and it works to go with it. Is it easy to implement? So we did a study in 9 countries, including Canada and the US. In fact, the program, is anybody here from Sandy Hill? Anybody here? Yeah, we did the program in Sandy Hill was in this study. And we were interested to see in these different contexts with different capacity, different amount of training, do these programs, do they show fidelity? What I talked about earlier. Do they have the ingredients of a good Housing First program? And sure enough, on a 4-point scale, 3.5 is kind of considered high fidelity. They came in overall as 3.4. You can see there was some variability. And where they came up shorter was with services and program structure. And that's context. And there's always going to be adaptations. So I'm going to jump ahead here, just give you a chance to ask some questions. But I should mention this. What contributes to program fidelity? We looked at that in these programs across the 9 countries. You need agencies that are all in with Housing First. They really have to be champions. They have to believe in it because you're doing something different and you're going to get pushback from the community in some circles because it's different. You also, though, at the same time, need partnerships. You can't do it on your own. Okay? And especially programs with case management, but even programs with assertive community treatment. You need help. You need services for your people. So you got to have partnerships. What gets in the way or obstacles to fidelity? Well, not surprisingly, the housing market. Okay? Cost of rents, low vacancy rates, and then insufficient funding to deliver programs. Okay? And that's also, it's kind of interesting in the Housing First world, we've got cities, like in Ottawa, there's 10 Housing First programs. The city funds some of them. The Ministry of Health funds others, and the capacity and the resources are quite different. So that gets you what's called in the evidence-based world lower voltage when it comes to housing first. Okay. Finally, is the intervention adaptable? Yes, fidelity, but listen, you're going to go into different contexts. We were able to test housing first in the Canadian study. In Winnipeg, 70% of people who received housing first self-identified as Indigenous. We also tested it with an agency in Toronto, Cross Boundaries, that brought anti-racism, anti-oppression kind of lens to the work. There's Housing First for Youth that's now being developed by the group out of York University, Stephen Gates and Melanie Redmond, who are doing some really good work in that area. We showed that it seemed to work for older adults. And we did a study as well with the Housing First program at Sandy Hill, and that's for people with severe kind of substance abuse problems. And again, it was shown to be effective. And even from where Simon is from in New Zealand, there's a Maori version of Housing First that's recently been developed. But you have to move away from some of the fidelity to do that, but not in a huge way if you have kind of the main ingredients. So just to wrap up, what do we need to do? We talk about Housing First 2. Okay. We've got to keep staffing Housing First programs with peer support workers. It's very variable across the country, the extent that that's the case. We have, and I say this, we need to shore up the support part, okay? We've got to get the mental health system on board. I said earlier that there were over 80 assertive community treatment teams in Ontario. Well, there's only maybe 4 that are involved in Housing First. Assertive community treatment it's considered the gold standard of support when we were in the middle of deinstitutionalization. I think there's a place, we go back to people being lonely, socially isolated. They want to do something now that they're housed. So we've got to look at education opportunities and even work opportunities for those people that want to do it. In the community mental health world, there is a model of supported employment that's actually parallels Housing First in its approach, that was tested in the Montreal site and showed some promise. And I think we need to do that, but we don't do a lot of supported employment to start with in Ontario. So we really have to find a way of scaling that up. Addition of IDDT, that's an American term, integrated dual diagnosis treatment. Okay? All of that to say that we have to figure out how to support people better around substance use issues in Housing First programs. Harm reduction is central to the approach, but we also have to figure out how to get people linked up better. And that's a systemic issue as well. We did a study a couple of years ago on strengths-based case management. Very interesting approach. Fits very well with Housing First principles and values. I think it can help in working with people, in setting goals, in making sure there's lots of choice. We need to enrich the support. We're doing a pilot right now at CMHA Ottawa where we're trying to bring, we started with social prescribing out of the UK. But we're now we're calling it community building, but we're using the work in the UK and trying to figure out how do we get people involved in activities that they want in the community. So we're doing a community asset mapping. And interestingly, in the needs assessment, high percentage of people we spoke to in the Housing First program at CMHA Ottawa, as well as their support providers, talked about wanting to do volunteer work. They feel they've gotten so much. This is how they presented, that they want to find a way of giving back to the community. So that's one that we're going to pursue. It's a pilot and see what that brings. Finally, I think we need to scale up Housing First to meet demand. We're doing a survey currently. As Simon mentioned, I'm involved with the Canadian Housing First Network. This graph is the number of Housing First programs in each of the 10 provinces. So you can see it's quite variable. We have 44 here in Ontario. I think, though, if we look at the numbers, the latest point in time count, 32,000 people were identified as being homeless across Canada. This is kind of, I think it was 20 to 22. 70% were chronically homeless. And that comes out to about 22,000 people. So we got to figure out, how can we bring housing and support to that group of people by scaling up Housing First programs. So this is what we're up against in terms of policy challenges. We have a complicated governance structure, right? You know, we've got these 3 levels. They are not all on the same page. They're certainly not all on the same page when it comes to addressing homelessness. As much as it's easy to implement, it does require the implication not only of different levels of government, but also different ministries. Housing, health, justice, youth would be child and family. So you really need, and then what's the one that deals with financial support? Is that community services in Ontario? So you've got to get these ministries that are siloed to work better together. I mentioned the absence of mental health. Rent supplements. Rent supplements are the lifeblood of Housing First. If you can't pay the rent, you're going to lose your housing. It's as simple as that. That's why, that's one of the main reasons why it works. Obviously, the support is vital. It's not just housing. You need support, especially to help people get established, and then you see how it goes. Okay. We've got a housing crunch right now in our big cities, Ottawa included, so that's an issue. We're doing, and we need single site housing. We need it for the 15 to 20% of people, and we need it for people who choose it as well. But it's the only thing right now that's moving. And I think we're going to have to figure out how much of each do we need, scattered site versus single site, and how should we set it up for people to choose, and taking into account their needs and so on. So that's a quick walkthrough. It's a lot of information, I know. I'm happy to hear your comments and questions. Thank you.
Thanks, Tim. A very erudite and clear description of 30 to 40 years' work. Dr. Moran.
Are you aware of any literature that integrates concurrent disorder treatment into the models so far? I volunteer for an organization here in Ottawa that we're trying to implement that, because it seems to be one of the biggest challenges for people's housing to become unstable. And
the CMHA Ottawa has worked at implementing the integrated dual diagnosis treatment. That goes back, actually, we did a study on that. It has to be over 20 years ago, where they have a series of groups based on the stages of change. which is what this integrated dual diagnosis treatment does. So they have it on site. But the problem is a lot of our Housing First programs in Ottawa don't have that kind of capacity. And then we have to figure out, okay, where can they get treatment? And it's deficient. It's deficient. That's a huge issue. That's a huge issue. And it puts a lot of pressure on the Housing First programs, the case managers, to try to get their folks linked up. But I know it's not enough, you know, and it's something we desperately need to work on, you know, because we're not, you know, when we talk about Housing First 2, that's an area that's recognized as you know, we're not making headway.
So a colleague from Montreal.
Yes, thank you very much for your presentation. I'm a psychiatrist and anthropologist at McGill University and working in a shelter as a clinician. And in your presentation, I was very interested when you spoke about the isolation that some people face. And so when you were then perhaps making a program about what Housing First 2.0 could look like, I wonder if there should be elements that are not about the program or itself, but that should think about the city or what, because isolation is never only in the person, it's also what the city makes available to people. So is there areas to think with there, I wonder?
Oh, I mean, I think we have to, yes, I think we have to figure this out. Where we're landing right now with the community building project at CMHA Ottawa, we're thinking, okay, yes, we'll really work to support people if they want to do volunteer work, if they want to do a yoga class, if they want to just do walks with groups and so on. But to do that, we have to figure out, because you can't just ask people to start that if you know they're coming out of God knows how many years of homelessness. So we're also thinking we're going to have support groups to go with it. And we're still in kind of the development phase. I'm not sure how that's going to kind of what it's going to look like, but I do think that that's really important. And that was tried even in the original Pathways Housing First programs. They did have groups for people, but it's, you know, that we heard that so many times. I love my apartment, but boy, the days are long. It's like they never end, you know. And I have nothing to do. And the other part of the problem is the rent's up gets you into the housing and paying the rent, but you're still living in dire poverty. And that's a huge, huge issue because you need money to be active. I mean, that's the reality. And that's something else we're going to face with this community building project.
So I've got a question from our online audience, because we actually have people online. So welcome everybody online. So this is a question from Emma Lowe. Does street psychiatry itself have its own fidelity measures yet, like Housing First and ACT do? Do you think it should? If so, what should they be? What should we borrow from Housing First research? Can you just knock that off?
I like that question.
Yeah.
That's definitely something you could develop. In fact, you could go beyond Housing First and just look at the evidence-based world in community mental health, because it's all supposed to be out there, and look at what are the ingredients of good community mental health services, because that's what the fidelity measures try to come up with. And you could see that could be a project for you, Simon. You could see what fits, because you'd have to figure out what fits. I mean, some of the stuff's not going to fit, but you know, you look at that area. We used to call it service array. Now we call it services that match participant needs. Are there some things there that you can pull out? Again,
Yeah.
not all of them.
So I'm going to ask a question. So one of the things you didn't talk about was about substance use and mental health outcomes. My understanding is that Housing First didn't make any difference to those.
Depends on the study. It's kind of interesting. It's a bit all over the map, that issue. So there's some reason. Well, let me start with the Canadian study, the big Canadian study. There were no differences between Housing First and TAU in terms of improvements, decrease in substance use. However, both groups showed improvements. Okay, so that's the Canadian study. The French study, the Housing First participants, I think it was after 4 years, actually consumed more alcohol than the people. So that was kind of part, you know, that was part of the story. Then there's some research out of the US, Deborah Paget has shown, where, you know, there's a paper she put out that on a housing pathways Housing First program, and I can't remember if it's the one in Philadelphia or Washington, but it showed reductions, greater reductions in substance use. So it's an unclear picture. Having said that, it needs work. There's no question about it.
Exactly, which is why this session is called Do We Need a Housing First 2.0? And I think one of the things we need to have in a Housing First 2.0 is much better clarity around what the clinical intervention is. Because if you look at the Housing First literature, it's based on, it's partly it just looks like a black box. So you either have an ACT team or intensive care case management, and it doesn't actually tell you what you actually do. And that's partly what this conference is about, is unpacking that black box. And the second thing is, well, one of the things, of course, even in its day, I mean, I can remember when ACT was coming out and when people were doing the randomized controlled trials, there was still some controversy about how actually effective it was. But coming up to date, I think one of the things that's one of the things you highlighted in your what next, 3 or 4 of them were around implementing clinical services. And I think we need a new model that isn't ACT, that isn't necessarily intensive case management, that is much more trauma focused. And I think that's the Housing First 2.0, is how do you design a trauma-based service for people who have been homeless or are now in Housing First?
Yeah. I think getting back to the fidelity question, though, and I think maybe if you actually look at the 40 items, it's actually quite specific about the clinical work that has to happen. It kind of sets the table as to what case managers and assertive community treatment should do. I agree with you that trauma-informed care, which is actually now being integrated into Housing First programs, needs to be part of the approach. Without a doubt, it needs to be part of the approach. The problem, though, where we're at with the support stuff, we don't even have intensive case management or assertive community treatment in a lot of our 150 Housing First programs across the country. So we're not even there yet. But I do think enriching the clinical work absolutely needs to be part of what we need to be doing.
Question at the back, Faye.
Yeah, my name's Faye. I took a few classes in like research methodology in like an undergrad of a handful of degrees I didn't complete. So I find it very interesting. I know that like it's easier to fund and get done things from like a quantitative point of view, because people really like having the results and like the evidence-based approach, like the evidence, like from a policy point of view, they want to have something to do with it. So I thought it was really interesting that you talked about like qualitative research. And I was like, how do you get more of that stuff done? Because I feel like from a not evidence, but like my own personal experience, like it's like on the other side of things from the research point of view, watching someone deal with the loneliness and then like go back to the community that they're involved with, like talking about trauma-informed care and like healing and stuff seems to like naturally come very much together, like people's wanting community to work through the things that they have going on. So it kind of feels like the qualitative stuff around learning about like the issues of loneliness that people are dealing with, like can lead to more like quantitative stuff through like operationalizing some of these kind of things. And I just wonder, like, how do you kind of like push those kind of things?
No, it's good. Yeah, this was a mixed method study. So we did have quantitative and qualitative. I would say though, in the world, you know, of working around the issue of homelessness, the research is probably more qualitative than quantitative. This actually studies an anomaly. We'd really never done a trial in the community. I mean, hospitals do trials. And it wasn't easy because of that, because it was brand new. But I agree with you wholeheartedly that you need, and that's why we added, and there's even a paper came out, Jeff Nelson wrote it, on why it's important to add qualitative methods and qualitative forms of data collection in this kind of trial in this area. So it's you're trying to, I guess you're trying to capitalize on both types of methodologies, because the problem you're faced with is the politicians and people in the policymaking world. You know, the qualitative stuff only gets you so far with them. That's why we needed economic evidence, you know. So it's a tough kind of road to, you know, to figure it out. But I think there's a place, quite frankly, for both. And once you get into outcomes, especially, I think you want the mixed methods, right? Once you're looking at outcomes of interventions.
I've got an online question here from W. Stewart. What are your thoughts on how Housing First has been impacted by the opioid crisis? That's question one. And how can it play an active role in addressing this increasing need? Perhaps this is Housing First 2.0.
I mean, I guess maybe, the opioid crisis has shown a light on how we need to do better around, you know, substance use treatment. And I think that applies to Housing First, but I think it applies to all our mental health kind of interventions. We, you know, I don't know how many years ago we went with, in Ontario, integrating mental health with addictions, that Center for Addictions and Mental Health, right? Some of you may have worked at CAMH, you know. But we're really not there yet where it's integrated. So I think, unfortunately, the opioid crisis has shown a light on that for our services, including Housing First.
I mean, our anecdotal experience here in Ottawa with Inner City Health is that, you know, there's been a number of supported housing units built, one of which is just up by Montfort Hospital. And it's been open, what, about a year and a half now? 40-bedded unit, 9 people have died. And 7 or 8 of those have been from opioid overdoses. And you wonder if there's something about being in your own apartment where nobody can necessarily see what you're doing may contribute to that. I just don't know. But
the first thing, though, it's important, you can offer Housing First in public housing or private market housing. We've gone more in Canada in private market housing because there's no public housing to access. I mean, what do we have? I think it's less than 5% of our housing is public housing. So you go over to Europe, you know, where it's, you know, 20% of their housing is public housing, or even a quarter, like, and more, and you know, in Scandinavia, they use public housing much more than the private housing. The issue I think you're talking about, though, in terms of the separating of housing and services, that's a kind of a part of the structure, that someone is responsible to keep people housed and somebody else is responsible to help them around their needs, to get proper health care, you know, to get what they need and to what they're interested in pursuing. And that's a really central principle in the approach. The one thing about, as I said, we need different kinds of housing. There's no question about it. And we need single site housing. We haven't landed, though, yet with single site housing on a model. They're very, very specific and unique, which is okay. But I think there's probably a place to also try to figure out, you know, what is good single site, you know, kind of housing and support. It's much better than it's ever been. I mean, if those of you that have been working in the field of mental health, you go back, and when I started at the University of Ottawa, I went around and toured all the domiciliary hostels in the city. And you got people living in the same bedrooms in very, very sketchy kind of housing. And it's a private business. And those still exist. So, you know, again, it's, you know, there's work to do around that. But it's different models with Housing First. There is a very unique model that two agencies now are pursuing in Ottawa, CMHA and Ottawa Salis, which has a lot of single site housing. They've gone out and bought condos, not penthouse condos or, you know, the real expensive ones. Condos come in all costs. So these are the lower end. And they use them to place people in scattered sites. So, you know, we're really going to have to be creative around this issue.
Hi there, my name is Rachel. Hi. I was just curious about, I think you spoke to in Housing First 2.0, more involvement of peers or people with lived and living experience. And I wondered kind of more specifically what that looks like. And I ask that because I'm a psychiatrist and in lots of settings where there's a peer, but the involvement ends up being in this very kind of tokenistic way, and the service barrels along as it was structured to do initially. And I'm fortunate to work for one group in Hamilton where the entire service is peer-led and peer-driven, and an incredible community has developed within that service. And so I just was curious about kind of what the role of, I guess, my initial question was what in this context of Housing First, what does the role of peers or people with lived experience look like?
I mean, obviously, in part a role model on the support side, you know, providing support. We're kind of thinking a little bit about with this community building project, we're going to need the peers. They're probably going to be involved with, you know, the agencies up to it, of co-facilitating the group support. I mean, it's finding places for peers. The thing is, this is another area in Canada, we're still working out what the role can be in community mental health for peers. And I know we're working with Options by Town and CMHA Ottawa on this project. They both have peer support workers, but their functions are very different in the two places. So you know, there's no set kind of approach. I think in the end, though, the support part is so important in their work, and finding that as part of a role becomes very important.
Great. Craig, there's a question over here.
Who are in our program as well, but also for people to house, as well as for the case managers when it comes to housing first, because of the loneliness, the isolation, and no one to watch them when they are using, and even just having access to a phone to be able to call somebody when they're using the program. So we've had way over 9 that have passed away in the past year. I think I can't even quantify the totals that we've had. And we've also, out of the research that was done from your research project, we have implemented a peer program at Sandy Hill, and it is co-facilitated by peers. And we also implemented a peer video program where community members who are housing first do how-to videos on how to work with case management and for people coming into the case management program.
So that answers maybe your question a bit, eh? But because there's an example though, but as I said, it varies by agency. But that sounds like you've done some good work there. Yes. Yeah. Well, good for you. That's nice to hear.
But it also illustrates another important clinical thing. I'm glad you said that, because a death in shared housing affects everybody, and everybody grieves in their own way. And that can be really difficult in those settings. And I think that's one of the clinical skills. Amanda down there is grappling with this in the supported housing she deals with. Is how do you manage grief in supported housing like that? It's a really big issue. And it's one of those things which it's not part of ACT's core mandate. It's not part of intensive case management mandate. But it's a really important clinical problem. Is managing grief with all these repeated overdoses.
It is something that's pretty forward thinking about it, and we do provide a lot of workshops for staff now and focus around and are encouraging more stuff, because at one point I think both Christmases, both Decembers, we've lost up to 14 clients.
Crazy numbers. Crazy numbers.
So, and there's a very unique relationship that happens with the case manager and a client in a housing first program, right? It's a very different relationship than anybody else has. It's very intimate. Sometimes we're their only contact. We're part of the process all the way through to where this person goes. There may not be any family involvement. So it causes quite a lot of moral distress, and we've had to take that very seriously.
Yeah, and I think maybe not in this conference, but another conference, we're actually doing a whole session on managing death and grief in the people that we serve, because it's one of those unwritten but significant issues. Time is just about up. Any last questions? Any burning questions anybody has? Just one more.
Thank you. My question is mostly about the eligibility and criteria that is serving most of our folks, and whether or not you'll be expanding in your research around people who are living in like rooming house conditions and not just homelessness.
Yeah. That's really interesting. I'd love to, quite frankly. I'd love to kind of, there's been talk about, how can we move the housing and support models forward, including, helping people getting out of rooming houses. And one of the things, in fact, in the Canadian study, that to be eligible for housing first, you either had to be absolutely homeless or what was called precariously housed. And you were precariously housed if you had an experience of homelessness in the last little while and you were in a rooming house, or out in BC, an SRO. So, the model, it should be able to help people, but the problem is at the system level, there's not enough to go around. So it gets kind of prioritized for people who are absolutely homeless, But we can't forget, I agree, we can't forget that group of people, because the thing that we're finding out around homelessness too, yes, it's one thing to get people housed, and obviously, and each story is a huge success. It's because you've changed somebody's life, and hopefully it's for good in terms of the homelessness. But it's the flow. It's the flow of people. It's like you do that for a whole group of people. Like we've got, probably 12,000 people across the country who are in Housing First programs. And we still have 70% of people in the latest point in time count who are chronically homeless. So we're not making progress. And so the prevention becomes really important as well. And probably the prevention is helping people into better housing, quite frankly. Yes. Oh yeah, and they can be dangerous, and yeah, absolutely.
Okay, thank you, Tim, very much. Thank you very much for all the questions from a very engaged audience. Thank you so much, Tim.
Thank you.
There's now lunch. You have an hour's break. Lunch is at the back. Please help yourself, and see you back here at 1 o'clock.